Hey guys, down here, welcome to Podiatry Practice Mastery. I'm going to go over today how I go over and explain to patients Achilles tendinitis and also kind of the same thing as plantar fasciitis. Now these two conditions, probably in your practice like mine, make up for the majority of my Shockwave and the majority of my orthotics, more so plantar fasciitis than Achilles tendinitis for the orthotics. But it makes up the bulk of my practice, which is, I guess, you would call it kind of more of a sports medicine practice that's heavy in sports medicine. So let me go over a little bit about my rationale. I've kind of come by and explained this in different ways, and I recently got a lot of really good feedback for the explanation that I used for Swift or for warts. I'm going to kind of do something similar the way I explain this to patients for plantar fasciitis. And I'm going to kind of go over a mock of how I explain it to patients, kind of the wording that I use as if I'm with a patient, and I'll kind of go over this with you right now. I hope this is beneficial for you. If you don't have this presentation, the presentation has changed over time, but you can go to patientpresentations.com. You can look at the one on plantar fasciitis, one on the Achilles tendinitis. The plantar fascia one has changed recently, so I do apologize if you're using it and you're not able to use it. I'm trying to simplify things to make it a little bit easier. I'm cutting out things a little bit. So I'm going to go over my new explanation where I'm almost cutting out the first visit. Okay, here we go. Hi, welcome to the practice. My name is Don Pelto. I'm one of the doctors here. Thank you for coming in. How did you hear about us? Oh, you came in from your primary care. That's great. We get many patients come in from their friends and families or primary care. From what my assistant told me, it sounds like you've been dealing with some pain in the bottom of your heel for over 6 months. She said that you have tried different shoes, you've tried some stretching, you've tried some icing, you've tried some Motrin and ibuprofen, and it sounds like none of that is working. Is that correct? Yeah. And she also said that you have pain when you get out of bed in the morning, and then throughout the day it feels a little bit better, but then at the end of the day you're having a lot of pain, and it's starting to throw your hip and your knee off, and it's just kind of frustrating. Is that kind of it? Yeah. So I just want to let you know that we see this a lot in the office, pretty much every day, a couple of patients, and we very successfully treat patients for this, and it can be very frustrating. What we did before we saw you is we got the x-rays, so I'm going to look at the x-rays with you. I am going to watch you walk and see if there's any problems with kind of the way that you walk, and then we'll do the exam and we'll go over some of the treatment options. Sound good? Okay, I'm going to start by having you walk. So I'm going to have you kind of walk down the hall, kind of go nice and slow so I can watch you walk. Now, as I'm watching them walk, many times I will note if there's any shoulder drop, if there's pronation, if there is any other asymmetry, and I'll document this, or I'll tell it to my scribe so they can document it, and then I'll show that to patients. Occasionally, if they have a very flat foot, I'll take their cell phone and I will record them walking to show that pronation. Okay, so based on your walking, I saw that you flatten out a little bit in your arch, so that's called pronation. And what I'm going to do is I'm going to sit down on the floor, I'm going to show you kind of where your foot goes, and then where it should go. So it should be lifted up here in the arch, because this puts a lot of extra strain on the plantar fascia when you're walking. And it just makes your foot work, and it also makes the back of your calf work. So the calf has to work more, especially this muscle on the inside. This is called the posterior tibial tendon, and its job is to hold up the arch of the foot, and it hasn't been able to do its job for a long time. And so when that muscle isn't working and that tendon isn't working, it takes a lot longer to get better from this problem. It sounds like you have good shoes. You have a Hoka shoes. You have some Power Steps inserts. Those are both good. You did the right thing. It's just they weren't good enough for your body. Because what I suspect, so as we look at your x-rays here, we can see that you don't have a spur. You have a little bit of a flatter foot, but that's all. So I would suspect that if we would look at the ultrasound, because I think that's a better way to look at the soft tissue, it'll show that it's very, very thick on your right side compared to your left side, because you only have pain on the right side. And what I find and what I suspect that I'll see is that thickness shows that it's been there for a while. It shows that your body's trying to heal it, and it can't. And so what happens is the tissue gets thicker. So instead of healing, I call that scarred. It gets thicker, it's less flexible, and it pulls more on the bottom of the heel, causing your pain. and that's what we call plantar fasciitis. Now, a plantar fascia, if you look at it, it's white. You can see this picture here that I'm going to show you. I like to show pictures here, so I'm going to pull up the slide deck. This picture here shows the plantar fascia. It's white. It looks very similar to the Achilles tendon. And if you look at fascia, or if you look at tendon or a ligament under a microscope, they're all pretty much exactly the same. It's just how they work in your body. Usually a tendon goes from a muscle into a bone. A ligament goes from a bone to the bone. And the fascia goes from kind of a bony region out and flares out into the front of your foot. And they all look the same, and they all look white. So I want to ask you, do you think white things have good blood supply? No, probably not. So they don't have good blood supply, and because of that, they have a harder time healing. So specifically, the plantar fascia has a harder time healing because there's not as much blood. And so one of the treatments we do helps stimulate your body's blood flow to that area, so it can get better, and so it can feel better. And that treatment uses sound waves to hit that. It's called Shockwave. It uses sound waves to hit the bottom of the heel. It stimulates the blood flow. It stimulates the process. Very similar to if you have your heart stops, and you have to use a defibrillator to start it up. When the healing stops in your foot or other parts in the body, you have to jump start it. And we find that Shockwave is a really good job at jump starting it, and it stimulates the cells in your body to heal things. It stimulates your own stem cells to start working. And there's nothing that has more research these days than Shockwave therapy. So what I find is that in your foot, you have tightness in the back of the calf, which is called equinus. And so I figure there's three things that we have to do. We have to help with that tightness, and there's a lot of ways that you can stretch. You can do foam rolling. You can do physical therapy. There's a night splint. That's just stretching. For your feet, you would stabilize it with a good shoe, and then possibly an orthotic. And then finally, we have to get that tissue to be less thick. And I find for a lot of my patients, what I used to do is I would say, okay, let's try some of these things that insurance covers. Let's try the night splint. I'll prescribe you a medication, and we'll see how things are going. And then depending on that, then we can go to the next step. But I find that just wasted 3 weeks, and it tended to do what insurance covered, but patients didn't get all that better. So what I would recommend is something a little bit different. If you want to try to speed up the process of getting better, that's your call. We can try the traditional things, which take about 3 weeks. Those are the things that insurance covers. But I find what works best for patients is the Shockwave, even better than anything else. I used to have patients do everything, do Shockwave. Sometimes they did cortisone injections, but it didn't really last that long. And I found that physical therapy tends to be 6 weeks, twice a week, so it's a lot of visits. What's working for my patients these days, and we can certainly do that, would be to get an ultrasound first, to look at the tissue, so I can really verify if it's a lot thicker. I'm going to assume that it is going to be thicker on one side than the other. So if it is thicker, my recommendation is going to be to do 6 sessions of Shockwave. I find by about the 6th session, it's going to start to feel better. Each Shockwave treatment is cumulative, and ideally I'd like to do 6 treatments within the next 8 weeks. That means if you have something going on, that's no big deal. So that would be the Shockwave. I am also going to make sure that you're doing your good shoes, you're doing some type of thing to loosen up the calves. What I find is that there is a chance of recurrence based on your foot type. So I find that if you're in a lot of pain right now, I don't think it's good for us to do the orthotics at this point. I recommend waiting a few weeks before we scan you for the orthotics until you're going to start feeling better. So usually about the 3rd session, I'm gonna scan you for orthotics. That's what I would recommend. They'll be back in at about the last visit where you're starting to feel better. Then you can put them in your shoes. A lot of patients, when they get orthotics right away, their heel is really painful and they can't even wear them because the orthotic tends to be very supportive, but if it's supportive on an area that's painful, it's not going to work for you. Okay, so I'm going to go get the ultrasound, have my staff bring that in, and I'll be right back. So I want to pause right here because this is the time where I go out, usually see another patient, have them think about it. One thing I didn't say that I usually say is that the 6 sessions are $1,500 for the 6 sessions of the Shockwave, and the orthotic is $600. So that kind of sits in, that price sits in, and then they are just kind of waiting in that, and they know the value of that. I go see another patient. They bring the ultrasound in, my staff does, and now I'm going to go through the ultrasound. Okay, so let's go through this ultrasound on the bottom of your heel. You can see here on the right side where you have pain, it's about 6 millimeters, and on the other side, on the left side, it's about 3 millimeters. So usually that thickness, right, is the hard part. So you have to do two things. You have to get rid of the thickness and the inflammation and that black, which is the swelling, and the best way to do that is the Shockwave. And then we want to support the area with an orthotic so it doesn't keep coming back and keep bothering you. In the past, what I found is that maybe a cortisone injection would make that feel better for about a month, but then the pain's going to come right back. And if you don't have an orthotic to stabilize and contour high to the arch, because what the research shows is that the higher the orthotic contours to the arch, the more pressure and pull it can take off of the plantar fascia. So this is what I would recommend. The 6 sessions of the Shockwave, they're $1,500 for the 6 sessions, and at the 3rd session we can do the orthotic for you. So we can set that up for you. Okay, so that's basically my presentation for plantar fasciitis. It takes a little bit of time to get used to the Shockwave explanation of the 6 sessions. However you do it, you can do 3, you can do 6. I think talking about the money is something important. They might come back with, okay, do you guys have a payment plan? We have care credit, so that's the payment plan that we offer for them. Patients say, well, I have a vacation coming up. Well, what I usually do is that's why I say ideally we should do 6 sessions within the next 8 weeks. Okay, so you can give a little bit of a time. And then normally, if I can, when I'm doing the ultrasound, I'm actually doing the ultrasound in my Shockwave room. And so then I offer them, we can start doing the Shockwave today. I think getting it started today, patients like that. They like to get going on that right away. So that is my presentation. If you want to see the actual slides that I use, you can go to patientpresentations.com. If you want to get together with me to kind of work on how you explain things, how you can kind of incorporate this into your practice, go to podiatrypracticemastery.com/audit. Do the audit. Tell me how you're doing in your practice, and then we'll set up a time to meet. I would love to have you help you with this in any way that you can. This is by far helped me for both plantar fasciitis and Achilles tendinitis. Those are the 2 most common things that I think most of us do, but it's brought a lot more revenue. And then the whole goal, once again, right, is to get to the $1 million mark and beyond. So having this process set up, I think, is very important. In the past, I used to have, like I said, I used to do all the insurance stuff first, and then I went to the Shockwave after 3 weeks, but many of my patients hardly ever got better. The ones that got better are the ones with the equinus. So if there's a really bad equinus and you think that just loosening is going to be enough, you can certainly try that. Or if patients just really aren't ready, what you'll find, though, is let's say patients, they want to try the stuff that insurance covers, right? So when would I do cortisone? If the pain is like an 8, 9, or a 10, or they're limping all the time, I might do the cortisone to calm things down. Also, if they really don't want to do the other things, I would start with the foam rolling, the night splint, the morning stretch, the shoes, the UFOs, all these other things. But I've already told them that stuff normally doesn't work. So when they come in 3 weeks, they'll be like, okay, yeah, that didn't work. You were right. Let's go on to the next step. There's very limited objections to doing the Shockwave for the patients. And then when you add, now this is another mistake I used to make. I used to do Shockwave first, and then maybe I would add orthotics at the end. What I've learned when I'm getting coached with this with someone else is that I offer the Shockwave and the orthotics. So the Shockwave kind of gets rid of it, and then the orthotics help with the structural component, the high contouring thing, to prevent it from coming back. So that's kind of the explanation that I give, and that's what I think works for patients. Okay, so I hope that's helpful to you guys. Thanks.